Welcome, and thank you everybody for joining us today. My name is Erin Sykes. I am the Director of Communications at Resolve to Save Lives, an initiative of Vital Strategies. Vital Strategies is a global health organization that works with governments and civil society around the world with the vision that every person should be protected by a strong public health system. Our speakers today are Dr. Tom Frieden, the President and CEO of our Resolve to Save Lives initiative, Amanda McClelland, the Senior Vice President of the Prevent Epidemics Program at Resolve to Save Lives, Robert Gordon, the Director of the Michigan Department of Health and Human Services, Dr. DaCosta Abuaje, the Director of Health Promotion at the Ghana Health Services and is the leader of the National Communication and Community Engagement Program for COVID-19 in Ghana, and Steve Hamill, Vice President of Policy Advocacy Communications at Vital Strategies. For those joining on Zoom, please note, we will use the QA function at the bottom of your screen for questions. If you have a question during the remarks, please enter it into the QA box. For those of you on the phone, you can send your questions via email to press@vitalstrategies.org. My colleague, Stephen Klepechka, will facilitate the QA and will make every effort to answer as many questions as we can get to today before the briefing ends. With that, I'll hand it over to Dr. Tom Frieden.
Good morning, and thank you so much for joining us today. These are difficult times. We're facing natural disasters, man-made disasters, and viral-caused disasters. These are unprecedented challenges. I just want to acknowledge that right at the top. This is the case in the United States and around the world. At Resolve to Save Lives and Vital Strategies, we remain focused on fighting the pandemic and saving lives. And today's briefing has one simple message: masks matter. The more we mask up, the more we can keep deaths down. When we all wear masks, we're all safer. Studies from around the world and around the US show that communities that mask more have less COVID. Wearing a mask, when combined with watching your distance, washing your hands, is one of the simplest, cheapest, and most effective actions that people can take to decrease their own risk of getting this virus and of spreading it to others. Today, we're releasing a new report, Promoting Mask Wearing During the COVID Pandemic, a Policymaker's Guide. It brings together the latest science and guidance to help communities implement evidence-based strategies and increase adoption of mask wearing. I'm so pleased to be joined by our panelists today who will bring to light the many ways that mask adherence improves the COVID response. Amanda McClelland will go into detail on how health departments can measure mask use in their community, because what gets measured can get managed, and what gets measured matters. It's only through reliable data we can adapt our attack on the virus. Director Robert Gordon will discuss Michigan's use of mask mandate policies and their work to address the needs of vulnerable populations. Dr. DaCosta will share the use of observational studies in Ghana to increase mask use. And finally, Steve Hamill will discuss the importance of strategic behavior change communication in garnering support for mask use. COVID is going to be with us for a while, and it's increasingly clear that people without symptoms can spread the disease, even to those who don't have, and that even those who do have symptoms are most infectious early on before they develop their symptoms. That's one of the reasons that masking is so important, because we could be infecting other people without knowing it. Masking gives us the opportunity at low cost to resume some activities while we protect other people. Now I'd like to hand over to Amanda McClelland.
Thank you so much, Dr. Frieden. And I'm going to go over the 5 key questions around monitoring and measuring mask use. The first real question is, what is a monitoring program? And essentially, a monitoring program is a way for communities, local governments, and organizations to measure performance of a specific behavior or intervention and take steps based on their findings to improve health and safety of the public. We've experienced with monitoring programs from many public health interventions, such as seatbelt use or hand washing in healthcare facilities. Ultimately, monitoring programs allow us to improve programming based on behavior change. The second question is really around why would we monitor and measure mask usage? And as Dr. Frieden said, it's really about what gets measured gets done, and aggregated data on mask adherence can be used to inform governments and organizations on how well they are promoting proper mask usage. If you set up a monitoring program and your data shows mask usage is high, that can tell you that wearing a mask is becoming the social norm, which will improve community-wide adherence. But now, if your data shows that adherence to wearing a mask is low, that data can be used as a trigger to improve and expand community engagement, education activities, and try to improve adherence. If your data shows that people are wearing masks, but maybe they are doing it incorrectly, then you'd be able to focus down on messaging around appropriate mask wearing. The whole reason we measure and monitor mask use is to try and improve our community's health by decreasing COVID-19 transmission. The third question, how do we monitor and measure mask use? Well, how we monitor and measure mask use really depends on two things: what your goals are and what your resources available to you are. Basically, the two overarching ways governments and organizations can measure this is through direct observation in person, such as Dr. DaCosta will discuss in Ghana, or by video. For direct observation in person, this might look like someone literally standing in a strategic location and counting the number of people who are correctly wearing a mask. For video, that might look like using live or recorded anonymous camera footage to count those with proper mask use. For both of these options, there are a few different sampling methods governments and organizations may decide to use. I won't get into the weeds on this now, but if you're interested, this is discussed in the detail in the report, which will be shared with you after the press conference. If organizations aren't well resourced, they may try a best effort method and have someone stand in one location and give a general count. Alternatively, you can have a more robust sampling method where you want a representative population, and so you go to one neighborhood, count a certain number of people, then go to a different neighborhood, and so on. So your sample looks like the general population of where you are. The fourth question, where would we monitor and measure mask use? Once measurement methods have been selected, it's important to pay attention to local context when deciding where it is most appropriate to monitor from. Essentially, you want to monitor locations where risk is highest, so wearing a mask is most critical. Think closed spaces like indoor places with poor ventilation, crowded places like public transport hubs, and close context settings like a store or on a bus. The last question, and one of the most important ones, is how can this data be reported? In July, we released a set of 15 essential indicators that would dramatically improve the ability of people in the United States to understand both their own risk and how well each state is doing to reduce that risk. The 15th indicator in that report was the percentage of people wearing masks correctly. It's important to show mask adherence over time so you can see how your community is performing and if interventions are working. It's also critical that this data has been made available publicly to improve accountability and transparency. Thank you.
Good morning, everyone. My name is Robert Gordon. I am the director of the Michigan Department of Health and Human Services. And it is an honor to be here today with Dr. Frieden and the Resolve team, which have provided wonderful advice and support to Michigan for months now. In Michigan, we've had some meaningful successes in our COVID response. Back in March, we were third among states in COVID deaths. Today, we've fallen to 9th, and COVID spread in Michigan is significantly less than in many neighboring states. Now, Michigan had an unmasked and armed protest in our capital that made a lot of headlines several months ago. But as a matter of fact, the vast majority of Michiganders have done their part. In May, there was a YouGov survey that found Michiganders were likelier to report wearing masks than residents in many states. And I think there's other evidence of that as well. Let me highlight 3 things we're doing to support the wearing of masks: strong orders, strong messaging, and free mask distribution. Governor Whitmer has used her emergency powers to change norms. Michigan was the 9th state in the country to issue an order requiring masks back on April 24th. Our original order covered only enclosed public spaces and carried no penalties. Even so, the order and its media coverage sent a powerful signal. After a sharp decline in the virus in May, we began seeing growth again in June. And so Governor Whitmer issued a second mask order on July 10th, which required masks in crowded public spaces, required businesses to enforce the mandate among customers, and added a criminal penalty. Anecdotally, in stores from Detroit to Traverse City, we saw a dramatic improvement in mask wearing. Now, if a potato chip company or a political campaign will invest in media, our task of saving lives deserves the same investment. So we've supported our orders with an aggressive outreach and media campaign backed by research. Early on, when rumors circulated that African Americans were immune from COVID, we partnered with a company called Apple Card to drive an innovative outreach campaign using social media to speak to the personal contacts of those who tested positive, particularly in Southeast Michigan. This was at a time when our contact tracing efforts really were not up to the level of disease spread we were seeing. And a part of that early campaign was about masks. Alongside our April order, we launched the My Mask social media challenge, that's M-I-M-A-S-K, asking Michiganders to post pictures of themselves wearing masks. That effort, mobilizing our pride in our state, reached 2.5 million people. Our next effort came under the tagline, Mask Up Michigan. We used that language rather than say, wear a mask, Michigan, because it conveyed the truth that wearing a mask is a sign of strength. Recognizing that masks were becoming a symbol in a divisive ideological war, we turned to the most famous division in our state. We launched an ad with the coaches from Michigan State and University of Michigan basketball and football teams coming together to promote masks. Now, I have to admit that our friends in North Carolina made such an ad first, but I know our ad was way better. We've also acknowledged that people sometimes don't wear masks because they are uncomfortable. From other public health contexts, we know that shaming is not an effective strategy to gain compliance. So we developed an advertisement that acknowledges masks are uncomfortable, but emphasizes what is even more uncomfortable, which is landing in an ICU. We have different versions of messages with individuals of different races. We test audience reactions and use those to develop new content. Finally, we are working to promote mask access. There's a raft of research telling us that when you make something freely and widely available, people are likelier to use it. It's a particular concern in our most vulnerable populations, where mask cost and access can be real issues. Thanks to a gift from the Ford Motor Company, and with resources from FEMA and from the state, we're distributing more than 4 million free masks in areas of highest need. So they're going out through our community action agencies, to homeless shelters, to schools, bodegas, tribal organizations. Any resident can call a state hotline and get a mask from one of our offices. So mask wearing is a responsibility, but we want to make it an easy one to honor. Thanks again to Resolve for the chance to speak today.
Hello, so my name is Dacosta Aborje. I'm the Director of Health Promotion at the Ghana Health Service, and I'm the lead for community engagement and risk communication for the COVID-19 national response in Ghana. We have conducted some study, which I'm just going to share with you. Certainly, we know that research and data are critically important in times of crisis, such as the COVID-19 pandemic. Understanding the specific needs of our population enables us to implement actions that will protect the greatest number of people as quickly as possible. Data shows that proper use of masks is key to preventing the spread of COVID-19. In order for mask use to be fully effective, it must be worn with both the nose and the mouth securely. To better understand mask use in Ghana, the Ghana Health Service recently conducted an observational studies within the capital city of Accra, which was one of our epicenters. there were some categories on observation. So 5 categories of persons were observed and counted. This included stationary traders, buyers, hawkers, head porters, we call them KIAs, and the disabled. For the observation focused on 3 categories of mask use: correct use, incorrect use, and non-use. The 3 surveys were conducted at various locations in the Greater Accra region. We were counting. People were standing in strategic locations counting. So what we did was we employed national service personnel and students who were on vacation to do this. After more than 42,000 observations, we found that the uptake of mask wearing was higher at around 82%. However, fewer than 50% of the people are wearing the mask correctly or were wearing the mask correctly at the time. Improper mask use leaves our people vulnerable and hinders our progress in reducing the transmission of the virus. So some of the selected sports were Ashaiman and others. I mean, obviously you might not know, but I'll share with you when we finish. So the key findings for the survey one was that about 42% were wearing the mask correctly, and about 25% were not wearing them, and about 32.6% were not wearing the mask at all, and 25.1 were wearing it. That's for the survey one. For the 2, those wearing them correctly were about 33.5%. And for the survey 3, we had about 43.3 wearing the mask correctly. So it was an average in terms of the 3 surveys, about 42-point-something%. In terms of the individuals, we categorize them as head porters, disabled, stationary workers, and hawkers and buyers. These samples were taken from marketplaces, about 4 big markets in Ghana, to inform our messaging. And what we have to do now is we certainly know that the research actually guided us in obviously presenting our messages. For now, Ghana is doing a little bit well because cases are going down. We have attributed it to the fact that adherence to the safety protocol seems to be very high, but there is that notion that the disease is gone. So we certainly have to enhance the community engagement and risk communication activities such that people will comply. There is an executive instrument by His Excellency the President, which is some EI 64, which makes it mandatory for all Ghanaians to wear the mask. But we have some challenges as well, because obviously we are in a political season, so enforcement has become a little bit difficult. But certainly we know that communication is key, one of the key elements in this COVID response, and we will reflect our learnings from these studies in going forward by encouraging proper use of the wearing of the mask, physical distancing, and washing of hands to slow the spread of the disease. So my overall remarks will be that the overall intention to use the face mask in Accra at the site surveyed is very high, with about 82% of the people surveyed possessing the mask. Less than 50% surveyed had the mask and they were using it properly. The male adherence to proper mask use was found to be better across all the 4 markets that we surveyed. The face masks used among the disabled persons were better than the hawkers and the buyers in the 4 markets. So the observational studies involved volunteers, like I said, research analysts, among others. And we spent about approximately about 50,000 cities. And public acceptance of the study has been good, but as the infections continue to reduce with political activities, the adherence to the wearing of the mask is becoming difficult. So we just have to continue with the advocacy, community engagement, and the communication. On this note, thank you very much for your attention.
Good morning, afternoon, or evening, depending on where you are. My name's Steve Hamill. At Vital Strategies, I work in our policy advocacy communication team, supporting strategic communication and behavior change initiatives. As we've heard, the science is clear. Widespread community masking is essential to slowing transmission of COVID to manageable levels, and everyone has a part to play. The communication strategies we put forth in our report are straightforward, cost-effective, they will save lives, and they'll blunt COVID's economic impact if taken up. Look, the population behavior change is hard, but the good news is that because of the threat of COVID, people are motivated to take personal action. And there's every indication that when governments promote masking, it becomes widespread and popular. For instance, research we're soon to publish in African countries across 18 African countries show high levels of support for masking and high levels of adherence. But this research also suggests variations in practices and uptake from subpopulations that governments have to try harder to reach. And we just heard the same from Dr. DaCosta. And in the US, from the studies and media reports we've seen and from what we heard from Dr. Gordon, the same is playing out. Secondly, we're worried that as the threat of COVID becomes less novel, people may mask less. Masking is a long-term strategy, and governments need to maintain a drumbeat of support. We know people wear masks when they believe COVID-19 is an urgent threat, when they believe that masks work, when they have access to the right kinds of masks and understand when and how to use them, when they believe their peers support it, and when there's environmental reinforcement like signage or masking mandates at work. And we should consider those who aren't masking with empathy. You know, most people are not knowingly endangering themselves or others. So at this point, for most people in most places, mask wearing isn't an information problem. From a communication standpoint, most governments have been good at using the bullhorn, and they should continue to do widespread promotion, but they should also engage directly with populations that are masking less. And that identifying that gap starts with research. So as we heard, observational studies show where and how people are masking, and Dr. DaCosta mentioned that they see high levels of compliance, but they have work to do in helping people adopt the right habits for mask wearing. And social science research such as focus groups are really critical to answer why people aren't masking. You know, if people aren't convinced that COVID is an urgent health risk, maybe they need to hear from different messengers. If they think that they're going to be judged if they mask, governments can engage sympathetic community leaders from different identity groups to show peer support. Or if there's an issue of access, focused giveaway programs can help. So with research in hand, we see the most effective approaches integrating 3 strategies. We heard them all from Dr. Gordon today. The first is masking mandates, from requiring signage or requiring masks in businesses to individual fines. And regulations also play an important social marketing role in that they codify community standards as the social norm. And the second is media campaigns, and particularly these days with digital media, governments can focus specific messages on specific communities to help improve compliance. And lastly is community engagement, working directly with community leaders to create trusted spokespeople and build feedback from communities. For instance, in recent research, Vital Strategies conducted with Black and Latinx communities on perceptions of COVID and contact tracing, we showed that messages that focus on community benefit delivered by peers were more effective than those from national health authorities. every government should be partnering directly with communities that are disproportionately impacted. And we heard a bit about each of those today. Lastly, I just want to thank our colleagues from Michigan and Ghana and those who we cite in this report. They're showing that these strategies can work around the world, and other governments should follow their lead. Thank you.
Thank you to our speakers. We will now begin our question and answer portion of the briefing. As a reminder, we'll be using the Q&A function at the bottom of your screens for questions today. We'll make every effort to answer as many as we can get to before the briefing ends. And if you're joining us by phone, please feel free to submit questions via email, press@vitalstrategies.org. Our first question comes from Elizabeth Weiss, USA Today. There's data out from Dr. Monica Gandhi at UCSF that masking doesn't just protect others, but also results in less disease in the person wearing a mask, and potentially milder disease if they do get infected because of the amount of viral inoculum they're exposed to. Do you have any thoughts about this? Can that case be made to the public that they're also protecting themselves?
Thanks very much. I read that article with great interest from Dr. Gandhi, Dr. Eric Gooseby, and others. It is a theory. The theory is a really interesting one. What we can say is we need to stick with the data. First off, the data is super clear that when communities mask up, disease comes way down. And we outline several of the studies on that, including from the US and around the world. One estimate is nearly a 47% decrease in community infection. Another estimate is up to 2/3 of a decrease. We know that if you wear the mask and you've got virus, you're less likely to infect others. The next question is, if you wear a mask and somebody else infects you, are you less likely to get sick? And that we can say it does appear somewhat less likely. The next question is, if you get sick, will you be less sick because you have less viral load, what's called a lower inoculum? And that we have to say, it's a good theory, it's possible, but it's not certain. And one thing I think we have to do in this is go with what we know, not with a theory when we're going out with communication. So we can say masks matter, mask up to get deaths down. When we all wear a mask, we're all safer. If you wear a mask, you're protecting me. If I wear a mask, I'm protecting you. And yes, wearing a mask may well protect yourself, particularly if it's a more effective mask. And this is something that we cover in our brief as well. Masks are not all made the same. An N95 mask is the safest, but it's hard to wear all day. A surgical mask is probably the next best, tight-fitting. If you're going to wear a cloth face covering, make sure it has 3 layers and is tight-fitting. So yes, masks matter to protect others and quite possibly to protect yourself as well.
Thank you. Our next question is for Dr. Gordon. What recommendations do you have for other states in the US struggling to increase mask adoption? Is there one strategy that has been most successful?
I think I would start with clear state orders. I think as Steve said, part of it is about the legal mechanism of the order, but a great deal of it is about the symbolism and the signal effect and the setting of a shared norm and the elimination of any doubt that we ought to be wearing masks. And in a lot of states, mobilizing state pride. This is something we do. We're very proud of Michigan. There's a huge amount of state pride, and that's true in most states. And I think having a governor stand up and speak from that position of pride and strength is very powerful. And then I would next say that investment in communications is important. I think it is easy to think about communications as an add-on or a nice to have, but in this case, it's part of the intervention and part of what we need to do to drive behavior change. And I think we have lots of evidence from other contexts that communications matter and clear messaging matters. And there's a lot of them that goes into effective messaging, and I could go on about that, but I guess I would just say we have tried to look to research on what kinds of messaging are effective. We've thought about other contexts like campaigns around safe sex or around opioid use. We've thought about advertising in completely unrelated contexts like politics. And we've tried to do research that is very specific to our context. And as Steve said, use messengers, both there's popular celebrity messengers that we've used, like Coach Izzo, the coach of MSU basketball, is about as good as you can in Michigan. And then we've used a lot of just regular folks, and actually we'll have something coming soon that is specifically addressed to different populations, and in particular folks who are not mask wearers and resistant. And we think speaking directly with folks who speak to that audience is really important. So more to come there.
Thank you. Our next question comes from Business Insider's Hillary Breck. Practically speaking, why doesn't CDC have the muscle to push back against scientifically bad policy recommendations? Dr. Frieden?
Well, the fact is CDC is part of the federal government. Until this pandemic, it has had a respected autonomy within the federal government. Now, even when I was there are always discussions, there are valid policy debates, but I don't think there has ever been a time before when people from the White House or HHS are dictating what goes on technical documents on the CDC website. This is dangerous. This is a big problem. It's a big problem for a lot of reasons. As some of you know, the CDC posted on its website recommendations on quarantine and on testing that are frankly not scientifically supportable. And this was done apparently at the behest of people in Washington. That's problematic because it undermines our trust in government. And I think trust is an essential component of any epidemic response. Anything that corrodes trust risks lives. It's also particularly problematic because we will have some really tough decisions to make as individuals, as scientists, as communities, as governments about vaccines. It's likely that some vaccines will be shown to have some effectiveness in the coming months. We'll need to know, are they safe? Who do they work for? Who should get them first? And that kind of question can only be reliably answered and believed if that trust is maintained. So I hope the federal government will recognize that what it did in the past week with both the FDA and the CDC is self-defeating. It's undermining trust in government. At CDC, there are thousands and thousands of hardworking scientists, experts, doctors, PhDs who care deeply about protecting Americans. And I hope they can get back to that work and do that without political interference soon.
Thank you. The next question is for Dr. DaCosta. How long did it take you to conduct the observational study, and was it expensive?
Thank you. So we are doing this observational study on a monthly basis. I don't think it is that expensive in Ghanaian context because, like I said, we're using our local manpower, which is our volunteers, our students, and others. Though we plan to do it monthly. So if you take that into account, then that will make it a little bit expensive. So that is what I'll say.
Thank you. The next question comes from Jesse Hillman from The Hill. The CDC now says people who aren't experiencing symptoms of COVID-19 may not necessarily need to be tested, even if they've been in close contact with a confirmed case. What is the impact of this on contact tracing?
Yeah, this is what I had in mind when I said this is not a scientifically justifiable recommendation. It's certainly the case that when test capacity is severely limited, you need to prioritize. But one of the things that we prioritize is testing of contacts. And that's not just to say you should isolate, that's to trace the chain of transmission. So if person A has contacts B, C, and D, and you don't test them, but they quarantine, that does some good. But if you test them and you find out that person C is infected, you can then do contact tracing of that person's contacts, E, F, and G. And you can get them quarantined, isolated, tested, cared for. Unless we figure out where and how COVID is spreading, we won't be able to stop it. So contacts, including asymptomatic contacts, do need to be tested. In fact, you can make a pretty good argument that it's more important to test an asymptomatic contact than it is a symptomatic contact. A symptomatic contact you can presume has COVID. An asymptomatic contact, you're not sure. But this is one of the areas where we need to continue to learn. We don't know enough about effective contact tracing. We haven't done it well in many places in the US, and the more we learn, the better we can do it. But we're not going to learn by closing our eyes.
Thank you. And I'll turn it back over to Dr. Frieden for closing remarks.
Sure. Well, thank you all very much for joining. I do want to emphasize that we've made one fundamental message here: masks matter. But there's another important component. We're seeing too much of what I call one-thingism. There's just one thing we need to control COVID, whether it's masks or testing or contact tracing or a treatment or staying home or banning travel or even a vaccine. No one thing is going to stop this pandemic. We need a comprehensive response, and it needs to engage communities and focus on empowering and following the leadership of communities that have often been disenfranchised in this country and around the world. Comprehensive action includes closing indoor spaces when appropriate, protecting health workers and health care, because otherwise even more people could die from the complications of closing down healthcare systems than from COVID, particularly in places like Africa. We also need to increase physical distancing, hand washing, ventilation, and the box-it-in strategy of strategic testing, rapid isolation, complete contact tracing, and supportive quarantine. Unlike most other measures, though, masks don't cost much. They're cheap, they stop a lot of the transmission, but they don't stop a lot of our economic activities. They're among the cheapest, simplest, and most cost-effective ways to fight the virus and to get our economy back again. Thank you very much for joining us. Please read the brief. It's really good, has a lot of great information in it. And working together, we can stop this virus. Wearing masks isn't about separating one person from another. Wearing masks is about separating all of us from the virus. Thank you.
Thank you for joining us today. We will send materials discussed in the briefing along with a recording of and a transcript soon. For any follow-up questions, please email press@vitalstrategies.org. Again, thank you for joining us.